Okay, so I'm going to go ahead and get started here. Good morning. As I said, I'm Cathy Poznik. I am the chapter coordinator with the Chiari I Cerebral Foundation. I live in Cleveland, Ohio. It's my first time in Vegas, and it's been a lot of fun. I have two boys with these conditions. I have my 20-year-old who has been through many surgeries. He has Chiari I, high pressure, and 2 shunts. There's been a lot of ups and downs over the last 13 years. I have my second son who has Chiari, had 1 surgery, did incredible until he hit puberty, and then he developed autoimmune issues and dysautonomia. So he's been very sick at times. He's been in and out of school. I'm happy to say he's a senior, and he's going to graduate this year. And like my older son, he is going to University of Akron, so they are holding their own. They deal with daily head pain, but they're doing okay, knock on wood. I am here to tell you a little bit about the Chiari I Cerebral Foundation. Our mission statement is to advance knowledge through research and to educate the medical, allied sciences, and lay community about Chiari malformation, cerebral myelin, and related disorders. Our vision and value statements underscore that we hold ourselves to the highest standards. CSF values accountability and transparency. We have met the Better Business Bureau standards by providing documentation that includes information in how we govern the organization, in the way CSF spends their money, in the truthfulness of their representations, and in their willingness to disclose basic information to the public. We also have the GuideStar Gold Seal of Approval, and that means that our GuideStar report is fully updated and we disclose all of our information on it. The last certification we applied for is the HON code, and that's the Health on the Net code. And that tells you that your information is written by medical professionals and that it is accurate. We applied for that last January of 2013, and we were told it's going to be 12 to 18 months before we hear anything. So we're keeping our fingers crossed that that comes through soon. The organization is governed by 3 boards. We have our board of directors. It's a very motivated group that either has Chiari or cerebral myelin or has family members affected by it. This group is passionate about what they do because their decisions can directly impact the quality of life for their loved ones and family members. We have the board of trustees that is international in scope. Their job is to ensure the fiscal responsibility of CSF and help to raise funds. The third board is the crown jewel. It is our Scientific Education and Awareness Board. We call it our C Board. You will recognize quite a few of these names. They are world-class physicians and scientists from around the globe. This group is charged with education and research and helping prepare our materials, review our grant proposals, and drive all of our efforts in the medical arena. Many of these individuals are involved in other boards, including the Hydrocephalus Association. To cover the cost of lectures and programs and research and to generate awareness, CSF has a number of fundraising and awareness events throughout the year. If you need more information or would like to attend any of these, please click on the events tab of our website. You can see we have the Bobby Jones Classic Golf Outing. We have the Dinner Dance for Your Cure in Twinsburg, Ohio. That's something that I've been putting on for years. We also have the Light of Night Children's Gala, and that's usually held in New York City or Washington, D.C. And we also have the Charity Ball every year in Staten Island, New York. I have a picture here from last year's Charity Ball. We were able to do, in memory of Heather Andrews, we were able to memorialize her, and we were able to have Janice Andrews come out, and her sister, and Heather's sister, Amber, attend, and her husband. And I feel like I got to know what a special person Heather was. I know many of you knew her. And I have to tell you just one memory, in putting together the talk about Heather last year, it was very difficult. And I have to tell you one memory that sticks out in my mind, since so many of you knew her. But Amber had shared a very special day with Heather, and it was on Amber's birthday. And it was while they were in the hospital room. It was Amber's birthday, and they were in the hospital room, and they painted their nails rainbow colors because Heather had once said, no matter what you're going through, life can't be all that bad if you can look down and see rainbows on your fingers and toes. And that just stuck out with me, so I wanted to share that with you today. CSF keeps very busy hosting various research meetings. Here you can see some of the 2013 and 2014 meetings specifically for research. We have our think tank. You can see all these on our website, so I'm not going to go through them all right now. Collaboration with other organizations should be our priority. We are here to find answers. Our focus includes Chiari, malformation, syringomyelia, and related disorders. This includes hydrocephalus, EDS, dysautonomia, to name just a few. We have, you will see here the past CSF research grants from last year, and 2 of these papers are already published. The first one and the last one are already published, and you can see those papers on our website. CSF chapters. So how do we educate? CSF listens, and we are thrilled to announce that we are making a big push during 2014 to set up chapters all over the USA. Chapters provide educational lectures, like this one you are attending today, and a source of peer support. In addition, these lectures are taped and put on our website under the Physician's Lecture tab. It is a free resource and contains great information that can be viewed from anywhere in the world. What exactly does a chapter do? A chapter is charged with increasing awareness, providing support, instituting educational programs, and raising funds in your area. We would like each chapter to strive for holding 3 meetings per year, like this educational meeting and peer support, and providing educational materials approved by the physicians in your local community, and also to participate in the annual United Night Walk, because we have a lot of fun doing that. Other things chapters can do. There have been many third-party fundraisers. The bottom line is we want you to drive education and awareness in your area. Right now on our lecture tab, you will find over 40 of these types of lectures taped. So if you have not seen that, go see if there might be a topic you might be interested in. And here's more educational lecture pictures. Oh, the picture before had Dr. Waro in it. United Night. United Night is a 1-mile casual evening walk all over the country to bring people together. Basically, we are trying to raise money for programs like this, awareness, research, and last year, what I wanted to tell you was that we had 2,300 registered walkers, and we raised almost $150,000. We were thrilled. And there is our Las Vegas group. Wow. Yay, Las Vegas. And here are some more pictures. I have to tell you, the picture on the bottom right, Orlando, they did the first ever United Night Harlem Shake. So that video is on our website. Tanya Jones is the chairperson down there, and she's trying to figure out what she can do for this year's walk. Okay, just let us know. We'll take you. And there's also solo walks. If you can't participate in a larger walk, you can sign up, fundraise, and do a solo walk in your area. Black and Gold Strong. What we're trying to do is there's so many awareness colors with all these conditions, Chiari, syringomyelia, and EDS, dysautonomia, hydrocephalus. So what we're trying to do for this year is have everyone bring their colors to the walk, or go black and gold strong to represent everyone with these disorders. So we hope to see lots of colors at the walk. And Instead of the balloons, as Lori had mentioned, this year we have our glow sticks that will represent a lot of the colors. So everyone will have these available. And you'll see it turns a lot of the colors. We couldn't get them to put the zebra print in there, so you have to turn it off for the white. We're going to have to put some black tape around them. Advocacy. Another very exciting project that has been in the works for quite some time is something called Unite at the Hill. This will be the final Unite at Night walk for 2014. The tentative date is Friday, September 26th. We're going to offer an educational lecture the evening before in Washington, D.C. area. We will also hold a training session, and CSF is going to help set up appointments and meetings with your representatives from your state. The really neat thing about this day is that Congress is in session. Congress is not in session, just the senators are. Congress is not in session, so if you cannot make it with us, we will help you set up on that advocacy day meetings in your local hometown with your local congressman. So you'll meet in Washington with senators or locally with congressmen. And we have started a video series on this, and we will be rolling out installments on that. Another thing that we're doing, at CSF we hear all the time, medical professionals just haven't heard of Chiari malformation. Or I should say, I think we go to the ER and we hear, you have Chiari? So we know that there's a lot of frustration for people and their families who have this disorder. There are stories of people not being diagnosed for years. CSF has worked with the medical board and created a campaign called Consider Chiari to help educate medical professionals about the symptoms and diagnosis of Chiari malformation. Here is a 2013 Consider Chiari lecture in North Carolina. It was for a group of nurses. This poster is floating around outside. This is one of the posters we use. We have been able to do this lecture at Grand Rounds in the Chicago Hospital, and this is another program that we hope to take a lot further. So we are asking people to consider Chiari. It could be the piece of the puzzle you are missing. So basically, consider setting up the chapter in your area and participating in the Unite at Night to help be part of what CSF is trying to do and making a difference for people who suffer with these disorders. Thank you. That was my little talk about CSF for you guys. I wanted you to hear a little bit more about what we do. At this point, we're going to bring up the Wright family with Andrew, Amanda, and Ava, part of the Ava Avengers team. And they have a few things to tell you.
She wore her black and gold just for you.
Black and gold strong with the purple.
We're going to share this mic.
Okay, we're just going to tell you. Can you hear me? Okay. Just going to tell you a little bit about Ava's story. My name is Amanda. This is Andrew, my husband, and this is Ava. She has type 1 Chiari malformation. As an infant, you don't have to stick that in front of my face. As an infant, she had mild seizures, so we wound up taking her to a neurologist, and that's how she was diagnosed. It was difficult at the time, of course, as parents to watch your child have seizures and stuff like that, but in the long run, it's a blessing in disguise, because if we didn't have that, then who knows when she would have been diagnosed. So from then, once her diagnosis, she had annual MRIs, and as of January of 2013, it started a very difficult year for us. That's when the films showed that she had a 19 millimeter. It had grown since the last one. So the neurosurgeon, recommended surgery, of course. And from there, we didn't want to settle with the neurosurgeon that we had here in Las Vegas. We didn't feel comfortable with him. So we did some research as well as monitor her symptoms. Some of her symptoms were she had frequent frontal headaches. She had severe leg and arm pain that would wake her up in the middle of the night, where it would take about a half an hour just to calm her down. And also, just her balance and coordination was really off. Like, she could barely skip. So we did some research. We had a connection at the head of neurosurgery at Philadelphia Children's Hospital, who gave us some recommendations on the West Coast. We cross-referenced a couple of those. We saw 3 different neurosurgeons. All 3 of us gave us a different story for the most part, different way that they wanted to do the procedure. We were finally comfortable with the one in LA, Los Angeles Children's Hospital, Dr. Mark Krieger, who we love him. And she was scheduled for her surgery June 20th, and she clearly she's doing great now. I'm going to pass it off now.
I don't even know what to do with this right now. Can you hold that?
Yeah.
Sorry, that was loud. All right. So, here's my notes. I'm going to go fast. I just want to piggyback on what she said where she was talking about her symptoms. With her surgery, it was very successful with her symptoms. On her way in, she was running along all of the little parking things like balance beams and jumping off them, and her balance coordination, everything is fantastic. She's had a great recovery in that regard. We really had a focus we've had, an issue leading in was the unknowns. How are we going to get her home from the hospital? There was so little information that we could find for the families, and we're going to touch on it at the very end as to our steps that we're taking, because as parents you're scared and we just didn't know. What do we expect? We found out what Chiari was, but what's going to be happening is what we didn't know, because there are so many unknowns. So with that, we went in with really just an open mind of what's going to happen, and her attitude helped a lot. She was very positive. And what I say to everybody, and our biggest emphasis that we took away, is her attitude was amazing. It's not because she was a child that she bounced back, it was her positive attitude. She was in the bed the night of the surgery, and she was like lifting her legs and grunting, like, "Are you okay? What are you doing?" She goes, "Yes, I'm exercising, because people want to see me and they're worried back home, so I want to get home." And it was just, she worked to get home and to get better, and she was always saying, "I'm going to be okay." And she never focused on what was wrong. It was what was going to be right and what was good. And that helped her so much. So for parents with children with Chiari or any of the similar malformations and adults, focus on the positive. It's easy to get wrapped up in the negative, but it does you no good to focus and live in the negative. Stay in the positive. It has helped her, and it has helped others around her that have changed their attitudes because of her. Through AVA and through the help of CSF, that's where we really got our strength and information, was with CSF last year. We have had so many people across the country that are strangers reaching out to us saying thank you, because a friend of a friend of a friend saw Ava's picture and read a little bit of this weird little kid in a superhero costume running around. They're like, "What is this?" And the symptoms set off red flags, and in their children, up to 60, 70-year-olds found out they had Chiari and were able to get relief and treatment because of this. So because of this and the success we've had and the impact we've had just from Ava being Ava and getting it out there in our support system of friends, Ava's Adventures, we saw her mention, those of you who were at the walk, we're actually taking that to another level because we had so much support, is in this next year doing really big campaigns to help the national groups and the local chapters with awareness. Because of our entertainment industry connections of Broadway and Hollywood and athletics, being able to put Chiari in the forefront and shine more of a light on it for people. And with that, we really want to help the families. That's what we found. The families are scared, and so being able to say, okay, you're not alone, and here's what our kids have gone through, and sharing success stories. And we actually have a brand new one to share with you. This happened within 2 weeks. Little boy in New York that was, again, I went to high school with a girl, and it's someone she knows through someone else whose son was battling it, and he was 3, and they were like, well, you have to talk to this little girl's parents, because this little girl had a very positive attitude, and the parents were very scared, and they had a rushed surgery. It went from being problematic to, we must have surgery in 2 weeks. So they were freaking out, and we were able to really be on through Facebook and the miracle of Facebook, talk with him quite a bit and keep them through it. And he had his surgery, and he bounced right back, and he just they followed that positive thing, and where they were starting, every time they would start to get scared and want to do something negative, their doctor told them that the kid couldn't get out of bed for 4 weeks. He can get up and go to the bathroom, but don't do anything for 4 weeks. And we're like, that's ridiculous. She was playing soccer the next day. They can't do what the child's able to do and what the child wants to do. They don't need to lay on a couch for 4 weeks and give their second opinion on that. And they did, and he's already playing and back home and doing a great job. So Alex had a great success story. So through that positivity that Ava's been able to spread, it's already contagious and affecting people back east. They had a big lecture on it. So we want to thank CSF for helping us when we were newbies in this, and we want to be able to help CSF in the future with all of it. So that is Ava's story. Can you say bye?
Bye.
And I do want to say a very special happy birthday to Ava. She turns 5 on March 10th. Happy birthday. At this point, I want to introduce our keynote speaker, Dr. John Oro from Aurora, Colorado. He's the Medical Director of Neurosciences at the Medical Center of Aurora and was the founder of the Chiari Care Center. He is a nationally recognized leader in the treatment of Chiari malformation. His unique dedication to aiding those afflicted with Chiari I malformation has made him one of the most sought-after surgeons in the nation. Dr. Oro has been listed among the best doctors in America since 2001, and he has been listed, 2001, he has been listed among America's top surgeons since 2007. He has held numerous appointments, serving on boards and committees at the state and national levels. CSF is very fortunate to have him as part of our Scientific Education and Advisory Board. We are thrilled with his energy he brings to CSF, and we look forward to continuing working with him. Thank you for coming all the way from Aurora, Colorado.
Right.
Dr. John Oro, neurosurgeon.
Thank you. Well, I tell you, it's been a wonderful morning so far, hasn't it? And it's such a pleasure to be here. It lifts our spirits as well. I think you need to know that. The marvelous and touching presentation we just have, and delightful Ava. It's an honor for me to be here, I guess is what I'm trying to say, and thank you. Let me get my slides up, and we'll know. All right, so today we're going to talk about some surgical advances in the Chiari malformation. In some centers, these advances have been around for a decade or more. But as already been alluded to, there's not a consistency in the delivery of surgical care throughout the country. So in many ways, these are still advances. We need to move this knowledge forward in a wider group of clinicians. As I often do, we need to all get on base and review a few basics before we get into the details. So we're going to look at the neuroanatomy, which is so fundamental to this disorder. Can you hear me okay? This is a side view of the back of your head, or the back of the head. The back is here. The face would be out there. This is called the posterior fossa. It's the bottom compartment. The upper compartment houses the upper part of the brain. This is the cerebellum. This is the brain stem connecting to the spinal cord. What's fundamental and crucial here is this fluid pocket called a cistern. It's when first identified, it was called the cisterna magna, the large cistern, okay, because it's important. Spinal fluid is created inside the brain cavities, the ventricles, through these little tufts. With each pulse of the heart, there's a fine ultrafiltrate, a watery substance that comes from the blood, and that's our spinal fluid. We make it with each heartbeat. It has to flow. This is a circulatory system. It's not thought about it that much, but bottom line is it's a crucial circulatory system. The flow is created in these ventricles. It can only really, the major portion gets out through two side openings and this small opening here. And Dr. Magendie got his name to it, so it's the foramen of Magendie. It flows into this cavity. It can flow up and down. So having this open is fundamental. Here's a slide now adding the bone anatomy. This is the bone at the back of the skull. This is called the subocciput, if you hear that term. This is called the clivus. These are the bones in the cervical spine, brainstem, spinal cord, cerebellum, cisterna magna. This is a very nice anatomy. From here to here is the hole at the bottom of the skull. This lower area happens to be called the cerebellar tonsils. Why? Probably when you look at the cerebellum from behind, somebody looked at these and said they look like tonsils. It's kind of confusing, obviously. People say, why are you going to operate on her tonsils? We're not. We're going to operate on the cerebellar tonsil area. This is a high traffic area. This is your brainstem. Inside your brainstem will run your heart. So rapid heart rate can be a symptom. The nausea center is right in that deep area there. Breathing centers are in there. And all the highways coming through, the sensory highways going up to the brain, the motor highways that are running our arms and legs, the balance highways are here. So not only nuclear centers, but highways and arteries. These are the vertebral arteries. These are important brainstem arteries. So that's the anatomy. What does a Chiari look like? It can look very different in many different people. It's hard to compare one person's Chiari to another because they are very variable. And I'll just show you a few pictures. This is a moderate, yet nevertheless, if you see from here to here is the hole at the bottom of the skull, this is plugged off. Where is the cisterna magna? It is not there. It's taken over by the cerebellar tissue, the tonsils of the cerebellum. So that certainly is a Chiari. Okay? And you can draw a line from here to here and measure the amount of descent or herniation. But let's look a little deeper. You can recognize the cerebellum. Now you're seeing these tonsils shoved into a point. So when we use the word pointed. But what isn't talked a lot about is what's happening to the brainstem. There are three parts to the brainstem: the midbrain, the pons, the medulla. Medulla it's all vital, but again, cardiac, respiratory, some consciousness functions, running the lower cranial nerves, swallowing in particular. This medulla is being stretched. So the tonsils herniating and hanging down, and you're going to see them pulsing here in a little bit. They are stretching this person's brainstem. There's going to be a myriad number of symptoms. And it can push the brainstem up against this bone here, the odontoid. So the medulla is this fat here, that fat there, and kind of skinny. It has a waist to it. It's not supposed to. And it's developing a kink. That doesn't belong there either, because as this is pulsing, it's kind of deforming the tissue into this mound here. You walk on the beach and you look at that mound of sand in front of your shoe. Okay, that's a similar type of mechanism. So Chiari can look different in different people, of course. Now, it's relatively straightforward to see Chiari on the MRI. But we have to be careful and not just have tunnel vision and only see the Chiari, because then we might not do right and the person may not get better. So as physicians and nurses I work with and other specialists throughout the country, we have to open our antennas. Yes, we see the Chiari. Yes, we're going to focus on it, but let's make sure we don't have anything else going on. And here's a list of some of the things that we have to think about. There are more, okay? But these are the more common ones. And we'll talk about this one in a minute. Could it be pain from the neck, called cervicogenic headache? Could it be a high disc that's really causing the main neck pain? We'll talk about this one. Could it be chronic fatigue? Is there Ehlers-Danlos syndrome? Is the pituitary flattened and gives you this funny name? I'll explain it briefly. A sella is the little bony cup where the pituitary lives, deep here and about that far back. And in CT scans a long time ago, you'd get a scan on someone, it looked empty. It looked like you couldn't see anything in there, and they called it empty sella. Now with MRI, we see that the pituitary gland is flattened there. And in some people, that can cause hormonal symptoms. And people with Chiari can have empty sella, as well as people without Chiari. So we can't ignore that. We at least have to take it into account. And there are a number of other disorders that we have to consider. Now, I'll bring up just two today, because if we think of advances in surgical therapy, we also need to advance on knowing when the right time is to consider a surgery, and have we ruled out other things that may decrease the success of the surgery. I think that's fundamental. We're trying to increase the success, and the way to increase it is improve technique and teach technique, but it's also knowing what else may be going on with the individual person. So let's look at someone that did not respond to Chiari surgery. This lady had come to me having had a posterior fossa decompression. You've heard those terms. Decompression of this back compartment. And the decompression looks quite nice. There's plenty of room. Here's the tonsil. It's not crowded anymore. They've created good room. There's no leak, no pseudomeningocele. It looks fine, but she has headaches, visual symptoms, dizziness. Her surgery 2 years ago, really no significant improvement. Okay, what are we going to do there? Looks like the surgery was done just fine. Well, one thing we can do is look at the cross-section of the brain. Okay. Now, there's no tumors, things are centered, nothing's being shoved one way or the other. Nothing major stands out unless you look at the fluid pockets. These are very small. Is this a tight brain? Is the person's brain tight? And you can do whatever you want here, but if it's tight, you're not going to get rid of the headaches, dizziness, etc. And these are quite small. And she has the Chiari pseudotumor syndrome. And I'll explain this term. It's not a real tumor. What is it? Well, Chiari pseudo is where somebody has a Chiari I malformation. You do your measurements, whatever measurements you believe in, and you can describe anatomically the Chiari. But they also have hidden pseudotumor. And hidden because it's tricky to find out for sure. Okay? So we got to be careful of hidden things, right? One study, Dr. Frim in Chicago, and his group, some years ago actually, looked at 36 of his folks that had not responded well to Chiari surgery. Significant ongoing symptoms or an early recurrence of symptoms. 42% had pseudotumor. In other words, they had the Chiari. Later he found out the reason they didn't get better, 42% of them, pseudotumor. That's a big red flag, okay? This is a small study. We need more work in this, but we're getting a clue that maybe 4 out of 10 people that don't respond might have this hidden syndrome. So we better start thinking about it before we even consider the procedure. It's not a real tumor. My thought of how this got this name is that probably years ago people would walk into the doctor's office, complain of severe headaches, and the doctor said, well, maybe you have a tumor. They'd get a scan, there was no tumor there. So fake tumor is what that means. There's a new name if you want to use it. And because, again, this name can be a little confusing, I still use it. That's how I trained, and it's easy to say. Or you can say idiopathic intracranial hypertension. Okay? Now, I do hear that some people are starting to talk about it online as IIH, and that's fine. But the name is actually a good one. Idiopathic, it's a doctor's language for we don't know what causes it. We don't know the cause. Intracranial, inside the head. Hypertension, high pressure condition inside the head. So we need to learn more about this. What are the symptoms of pseudotumor cerebri? Headache, often worse in the morning, usually diffuse, worse with coughing, sneezing, straining, blurring of vision, maybe graying out of the vision, double vision. Dizziness, nausea, vomiting, ringing in the ears, a sound of pulsation in your ear, problems with learning, memory, and thinking. Pretty well close to Chiari malformation. Okay? So if people are complaining of these symptoms, you see the Chiari, you could say, well, Chiari's causing that, treat the Chiari. But what about if pseudotumor is hidden? There may not get better. So we need to dig in a little more. What causes this high pressure condition? We're not quite sure. We have some suspicions. Maybe the spinal fluid is not being absorbed as much and therefore leads to pressure problems. That doesn't quite fit with the case I just showed you because the brain itself is tight. Okay? Maybe the vasculature, the circulation, and it leads to sort of more water in the brain and that gets tight. It's possible. Maybe the veins aren't draining as well and the brain gets engorged. Okay? And maybe we've got a problem with the vein drainage. And that can occur in a few people. But in our clinic and others are starting to wonder more about actual brain inflammation. Okay? What causes brain inflammation? What is associated with pseudotumor cerebri? People can have pseudotumor because of a drug. I had a young girl, 17 millimeters of Chiari malformation, 16 years old, 17 years old, something, and terrible swelling in her eye nerves, papilledema. I can't treat a 17 millimeter Chiari when the brain is obviously tight. So we sent her to our eye specialist at the University Hospital in Denver. And she diagnosed the medication that was causing the pseudotumor part. And it was an acne medication. It was minocycline. Okay? So we have to wonder, we have to ask ourselves, could it be related to this? Or could it be one of these disorders? These disorders can lead to pseudotumor. Okay? Now many are able to be diagnosed, but the more common one is right there. Once the body mass gets above 30, we have to start worrying that pseudotumor may be a problem. And why is it related to obesity? Well, one argument is that the mass in the abdomen puts pressure and it sort of increases the pressure in the heart, and therefore the vein blood doesn't get out, you know. It just, pressure's too high, it's going to stay up here. We're going to have a constant increased venous pressure due to this abdominal mass. Okay, you got that picture, right? Goodness, I don't know what I'll ever see there. Now we also, though, now more lately, past 5 years, maybe the specialists have known this even longer, abdominal fat. Most of us grew up thinking that fat was just a storage area. It was benign. We just left it alone. And in some people, though, it's a source of chronic inflammation that now we're seeing could lead to brain inflammation. Okay? And these inflammatory substances, let me stop. It could be simply direct, they're called cytokines, from the abdominal fat going to the brain. Or it could be that inflammatory substances are getting through our gut, breaking the barrier, and then they break the internal barrier to the brain. And now there is evidence for that. So when you hear the term leaky gut, it's not that our gut is sort of leaking into itself, into the intestine. It's that the barrier is broken and sludge in our gut is leaking into our bloodstream. And that's the common disease is celiac disease. It kills about 42,000 kids in the world a year. It's due to gluten. Maybe 1% of people are affected by that. There are probably other substances. But the question has been, can these substances that don't belong in our bloodstream, can they break through into the brain itself. And now we've identified 3 neurological disorders due to gluten. Again, gluten's the only one we know, and that's gluten ataxia, which is a condition that affects the cerebellum. There's a gluten spinal inflammation, and there's a gluten neuropathy. So this is a new area, but we have to think about neuroinflammation. How are we going to try to diagnose it? What about if I have someone that has a BMI of 38 and has clear Chiari? I don't know if they have pseudotumor. And so surgery might work or it might not work. How do I find out if they have pseudotumor? It's tricky. I don't want to do a spinal tap because they're crowded and hanging down. So if they're tight here, to measure the pressure you would do a spinal tap. I'd rather not do that. So we do a visual exam and look for swelling of the eye nerves, but not everyone will have that. We do the MRI, I've shown you that. We may look at the veins in the brain. In some cases where it's only 5-6 millimeters, the tonsils are rounded, they don't seem to be impacted. A spinal tap with a thin needle, it should be quite safe. We can find out that way. But in some of my folks, I'll tell you right now, people that come in with very high body mass index, where these blood tests, let me say about these, this is what we're now using more and more. This is an inflammation marker. The higher this is, the more likely a person will have a cardiovascular event. This hemoglobin A1C, which measures your blood sugar, it's an indirect measure of blood sugar, is now correlated with brain atrophy if it's too high. And then vitamin D, homocysteine also with brain, and vitamin D is a protectant, if you will, and it boosts your immune system. So past week I've seen 2 with high CRP, high hemoglobin, so they've got high inflammatory markers, and sometimes 4 or 5 times normal, okay, so quite severe, and a very low vitamin D, which is what they would need to try to counter some of that inflammation. So clearly we're not going to do surgery in those situations. We're going to try to straighten this out first, okay? So let me move along, and if we identify or suspect, highly suspect pseudotumor, we can discontinue the medication if we can identify it. If they have an underlying disease that triggers it, we obviously seek the specialist to help us treat that. If they are one of those folks that with the brain MRV, it's called an MRV, shows these big veins are narrow and they're not draining their venous blood very well, there are specialists now that through the groin can drive a catheter up and kind of relieve that stenosis and crowding. Okay, that's early work, and there are about 4 or 5 centers in the U.S. right now that are doing that. We don't have long-term studies. We can use a medicine to decrease production of spinal fluid, and that can help lower the pressure in the tank and help them, at least temporarily. We can, if there's no Chiari and you have pseudotumor, we can put a shunt down in the lumbar spine to drain down the spinal fluid pressure, try to get rid of the symptoms. But this is the key. So people with Chiari pseudotumor that have a very high body mass index, it's the only Chiari that someone can take care of on their own. They can cure the pseudotumor part at least by significant weight loss. And if their Chiari malformation wasn't too severe, we believe that then the tonsils will pull up some. So it's again a new area of interest. And on the other hand, I have a number of my folks right now that have been trying to lose weight. They know they've got issues. Their blood markers are very high. They're inflamed. And some are very grateful to have just gone ahead and had a gastroplasty or a lap band and then get good relief of their symptoms. Okay. Are there any questions about this area? Because I'm going to move more into surgery here in a minute. Yes, ma'am.
When it comes to the stenosis, are you specifically talking about the veins, or what about like aqueducts as well?
Yeah, that would be hydrocephalus. Good question. That would back up the fluid and then you'd get big ventricles. So yeah, it's a new one. Yes. So the question is, are we talking about stenosis in the veins themselves that handle the vein blood, or in the aqueduct, which is a very good question. It's one of the channels where the spinal fluid compartment flows. It has to get through this little tunnel to get to the other areas. If the tunnel, the aqueduct were closed off, those pockets would blow up with spinal fluid, and that we'd call hydrocephalus. Okay, you've heard that term, right? On the other hand, if it's the big vein sinuses, you've got to keep in mind with each heartbeat, the brain engorges with blood. Your brain will actually move, and we're going to show, hopefully soon, some video, a little bit of that. It has to move. It's just being hit with this pulse, so it enlarges. It's in a box, closed box, so in that closed box, the only way it can go is down. So you've always got this downward pulse that, and if your tonsils are crowded and your brainstem's jammed, that's happening 100,000 times a day with each heartbeat. You cough and sneeze, you're going to jam it more, and that's why you don't like that headache, okay? Or people with Chiari don't like that headache, okay? Now, the pseudotumor part, the engorgement or the tight brain, if you will, if the vein blood's not getting out, that's going to back up inside the head. The vein blood's going to back. And so we have, especially back here, we have these large veins. We have all the smaller deep veins get into bigger and bigger veins until a big large vein there, two big large veins go mostly down your jugular, although some other areas. If one of those big highways is blocked, the traffic's going to back up. You need to clear that highway. And the way they can do it is run a balloon catheter, a little catheter here, slide the catheter in the tight spot, blow up the balloon, or put a little stent to try to now get that highway to start flowing. It's early work.
So is that a temporary solution?
That's the problem, and that's why I keep saying it's early work. Specialist at the University of Colorado does that type of treatment. Very encouraging that first year. Right now he's in his second year of experience, and he's getting, he's seeing some of those want to narrow just beyond the area of the stent. So it's early. In other words, we don't know how long it'll hold. So, all right, let me move on. Surgical treatment, we've written about our impressions in a review here. I'll just pass along. Our goal is roughly, in some form or fashion, to go from this crowded situation to some space back there. Okay, I think most of you will understand that. It's probably easier to see it on the MRI scan. You see a very narrow tonsil, you see an elongated brainstem, and you see correction of that with a decompression. The brainstem itself has even become more plump. And that's the goal that we want to achieve. We're going to talk about some advances, what I view as advances, and again, many have contributed to these thoughts. And one is what I like to call the choke point. Surgery should focus on the choke point. The choke point is at the foramen magnum itself. That's the most crowded area. Unfortunately, what we'll sometimes see in people who have had surgeries, when you first look at this 3D CT scan, which we get in our office in people who have had surgery before, it tells you and I exactly what bone work was done. Okay, there's no argument. You read the op note all you want, you're not going to get as much detail. Okay, and this looks, hey, they worked hard to take some bone out. But the bottom line is where you really need bony decompression, where the Chiari is choked the most at the base of the skull, it's narrow. The reason it stays narrow in some is because this bone is harder to get out than this bone. So this idea of focusing on the choke point, I think, is important in reducing the chances of symptoms persisting. So we have to get reasonably wide. You can't get wider than the size of your canal, but there's no need to leave these knuckles of bone. And I've argued this in other conferences as well. And this was pioneered at the Chiari Institute in New York many years ago, but again, not everyone uses this. We believe it's important to do intraoperative ultrasound, and I'm going to show you some of that. For safety, you can see where the blood vessels are before you open the dura. You're going to see the pistoning, and it's beginning to tell us about the anatomy. We can see from these surgical photos in the ultrasound how the tonsils can catch. We all have a little hump at the beginning of our spinal cord, at the top of our spinal cord. And these tonsils seem to catch on that hump and then cause that kink that we've known so much about over the years. We happen to use this unit. There are many units. I'm going to get you oriented. You can understand, you can read this scan, you can see the crowding of the tonsils. Very severe, very stuffed, no cisterna magna. Now lie that person down, which most of us will do the surgery in this position, okay, in a special table. And then now orient yourself mentally to what you're going to see in the next slides. This is the brain, tonsils, brain stem. The surgeon's going to come in from behind, okay? And then now the bone has been removed, okay? So the bone is, well, the skin is open, the muscles are moved to the side, the bone decompression has been done. Now we can put the ultrasound, okay? Can't do it on the bone. It won't give you a good image. You won't be able to image through it. Now you can see the same tonsil. This is important to kind of be able to understand the next slide. So the head is this way. This is the brainstem that's going to turn into the spinal cord running that way, so her spine is running that way. This is the bone, the odontoid of cervical 2. So in surgery, we can tell again that there's minimal space. As a matter of fact, there's a thick band that I already removed here, and it relaxed just a tiny bit. But the bottom line is you see the crowding. Now let's see if this is going to all work out. This is Chiari. Maybe you don't see it too well, and I hope these videos play here. Now this is not a very severe one, and it's a short few seconds, then it loops. But this is the pulsation. That's not very severe in terms of the pulsation. This is a Chiari. Now hopefully these surgical views won't be too disturbing to most of you. The feet are that way. It's a triangular opening. The arachnoid, the thin inner membrane inside the dura, is very fibrotic. There shouldn't be tonsils there, and yet we're seeing cerebellar tonsils. Okay? We're lifting up the tonsils. Will the lights dim back there a little bit? If not, that's okay. But we're dissecting through that fibrous membrane. Here is the tip of the tonsil. You can't quite see it. She had a tiny little callus. Some people will have a more significant callus. I've certainly got pictures of blisters in the tonsils. So if there's a neurologist that is not quite sure, just show them a picture with a tonsil and a blister and ask them to explain that to you. Here's another Chiari. We're going to look at the same situation. Here is and that's the brain pulsing. The brain is pulsing with each heartbeat, and the tonsil is jamming. It's causing this upward lift. There's a rush of fluid here, and that lifts it just like almost like an airplane wing would. These are the very large, full tonsil. The tonsils don't have to be equal in size. This is the left tonsil. This is that little hill, if you will. I went ahead and shrunk that down off of the hill, okay? And that we touch it with a little bipolar, a pincer forceps that has a little current in between. Do it very safely, but very carefully. And then we're going to sew in. I sew in a person's own tissue that I get from underneath the scalp in a small incision in the back. That's my preference, is to use a person's own tissue. Severe Chiari malformation. And I think maybe you'll see it better in the next one. But here the two tonsils jammed, crowded. An early blister. That's not a blister there, but it's early. You can see that there. Okay? That's again from the impaction and crowding. That's going to be shrunk back. The tonsils had got caught on this hill, so that's what it can allow it to stretch the medulla underneath. I shrunk that tonsil as well. Here's another one. Now these are a little more bothersome. This is the bone. So with each tonsil compression, that brainstem in this area is being affected. Okay? And in a lady that passed away in the 70s who was 65 and had Chiari all her life but had never been treated, she donated her brain to science, and they analyzed the internal brainstem, and the relay centers were abnormal. There was loss of nerve cells. There was loss of shielding around nerve cells. So I think we're starting to demonstrate why that can occur. This, again, tonsils, very stuffed. I mean, C1 is removed. This is all underneath where cervical 1 should be. The tonsil should be up here. And again, caught on that area, a little bit of blistering or a callus on her right there. I've got more severe, but that wasn't my point. The fourth ventricle, part of the brainstem, shouldn't have developed there. It should be up higher. That's just part of the congenital anomaly. Very crowded, very tight. These often roll into the fourth ventricle and crowd that. And again, had to shrink one down, shrink two down, and once we're not going to close this back down. We're not going to close this. We're going to sew a patch in. We're going to make a tent over that area to give more room. Okay? And then, so again, this is before and this is after. Okay? And then again, a patch. I think I have one final one of these to show you. Very impressive. And so there's a rocking, there's a pushing. Here's the bone right there. As a matter of fact, you can see the brainstem's got a little dent in it there. Okay? So Chiari can be quite severe, can be quite, cause quite a number of symptoms and be quite troublesome. There's the before and after. Here's the before, after, a patch. Okay. All right, so I hope you had a sense of what's going on in that area. I showed you the more involved ones, but that earlier one was less involved. This has been known about for some time, but it's not routinely applied in the treatment of Chiari syringomyelia. You know that in some people with Chiari they can have a syrinx. My philosophy, and I think others would agree, other specialists, in that case, you need to look between the tonsils and make sure there isn't a covering that never opened during development, okay? And I'm going to try to show you a case to try to prove a point. We need more work in this area. I've opened it here. That's the fourth ventricle. So this is one of three drain holes at the cerebellum, and it's closed off congenitally. It never opened. If you have syringomyelia or someone has syringomyelia, I think you don't want a procedure that just opened the dura, not the arachnoid, and they didn't look. We don't have the numbers yet, but I'm going to show you this case. She came to me after Chiari syringomyelia decompression. The syrinx remains very large, very large. The decompression looks reasonable, okay? It doesn't look impacted here. There is a clue. This is a little bigger here, the fourth ventricle, but the bottom line is I told her, I said, you may have some adhesions, some scarring, etc. We could try, I don't want to put a shunt in her spinal cord if I don't have to. We want to try to get rid of the syrinx by improving the dynamics here. We did a cine flow study. She had a little restriction of flow, not terrible. But the operative note from the previous surgeon had not made a comment about looking at the foramen of Magendie. So I said, I can look for adhesions, I can look between the tonsils and see. But, I don't know. Well, what can I do, doctor? I don't want to shunt, and I'm getting worse. Okay, so now, I did find a few adhesions. I think they aren't bad. That's a little sticky scar there. Yeah, it's there. Not terrible. There was one other little sticky scar off to the right side. You see it there. Here's the tonsil, here's the brainstem, etc. I didn't think that was enough to cause her symptoms. Looked between the tonsils, and sure enough, she's got a veil over it. It is not open. It is closed. It's congenitally closed. And then I'm going to open that veil. You can see with a fine little, we call it arachnoid knife, we're opening that veil. And now you can see that the veil's open. That's the drain hole now. That's what we want. Here's her 2-month result. Dramatic improvement. Okay? So I don't think it was that little bit of scarring, tiny little scar. I think it was the veil of the foramen of Magendie. Therefore, even if this only happens in a few people, I think in Chiari syringomyelia we need to look at that. Because studies will show it's there about 8 to 12% of the time. So 1 out of 10 people are going to fail with Chiari syringomyelia unless you deal with that, is probably what the literature in the future will suggest. Obviously, we can't prove that. Let's move along. Our clinic for many years and some others believe we should reconstruct the area of bony removal. I designed these plates back in about 9 years ago now, 2005 or so. And I've spoken about them before. I just want to tell you our newer one. So this is what we do. We bend it. The duroplasty, the repair, when we sew the patch in, it balloons out. This goes over it, not to compress it. This is what it looks like on a scan. And I've just redesigned it. I've probably used this now 15, 20 times. Has a midline marker. It's a little longer in this direction, and that seems to be working as well. And I think the advantages here are two. One is, of course, it keeps people from having the dent that they can have from these operations. But more importantly, the bone that this replaces, if you will, there were muscles attached to that bone. I treat a lot of neck problems in later life, and those muscles are very important to us to have natural curvature. So to me, it just seems to make sense to allow the muscles to attach to something firmer. All right. That's one of the sweetest notes I've ever had. So. But outcome and measuring outcome and comparing outcome is something we've and others have pushed for quite some time, and we're finally getting there. There are no outcomes, or until recently there have been no outcome tools to measure Chiari malformation. So comparing one center to another center in terms of measured outcome has been difficult because there have been a number of different scales. And out of one of the Conquer Chiari meetings, two groups, Dr. Frim's group in Chicago and our group, went back to our shops and went to work. Dr. Frim's scale is available, and we believe our scales actually complement. Ours we view as the only and first Chiari outcome scale that measures symptoms, symptom profile. It gives us an idea of, if somebody asks me, what are my chances that the dizziness will get better? What are my chances that the headaches will get better? We hope that this study will help narrow that down. We have a study ongoing now with 50 folks that we're following, and we've already published this work. What you would do if, and other studies have asked us to have this, and they're going to use it in their outcome. So it's 57 questions. It started much larger, but with a statistician, they analyzed, narrowed it down. The statistics, for those of you that are into statistics, the Cronbach score is very high, and our statistician believes the survey has strong reliability as a survey tool for Chiari. You would answer questions in this fashion, never, rarely, some of the time. You would do it before surgery. You could do it 1 year after surgery, 2 years after. We hope eventually to have 5 and 10 year outcomes of Chiari symptoms. And we can score it. No symptoms, no disability whatsoever, 0. The highest is 228. So my nurse will email me periodically, Mrs. Jones scored 160, and now she's at 92 2 months later. Or maybe she's not, okay? But it gives you now a little bit more of a concrete measure, okay? And you can break it out into these different components, etc. And then winding down a little bit, if a Chiari is present, outcome can certainly also be measured by what's happening to the syrinx. I mean, what you want is, in someone with syringomyelia, you want the syrinx to shrink. And that's through these type of scans, follow-up MRI scans. Severe Chiari, very crowded. The spinal fluid is white. No spinal fluid here around this. Yes, we know there's a disc problem here. We're going to keep that in mind. The neck angles a little bit. Big syrinx. Decompression, response to syrinx. So it's one of the more gratifying things in in the past 15 or more years to understand that if we can get rid of the crowding there, for many, many people, we should be able to get rid of the syrinx that's associated. Here's a whole accord syrinx. It ran all the way down almost to the end of the thoracic spine, and 2-month follow-up. Here's the same thing from here to there, and it's fairly consistent. I'm just going to, can we turn the lights back on now, please? Thank you. So just winding down a little bit, I want to kind of point you to a resource that I developed over a year ago and need more time to work on. You know how our lives are. But one of the most, agonizing things that I hear when I go to these sessions and meetings is, and seeing my own folks in the office is, my doctor didn't understand this, doesn't know about this. They've never heard Chiari, or they heard it about in medical school. And that's a very frustrating situation. I mean, I can somewhat understand it in the sense that medicine is very complex. We unfortunately are somewhat into silos. If one of you comes up and talks to me about what your choices are for knee surgery, I'm going to give you just a rough outline. It's just not my area, okay? And so again, we're in silos. And crossing information across those silos has been very difficult. And there's that time shortage. And unfortunately, physicians continue to be under more time pressure. I mean, I'm hopeful. I think we'll have some disruptive technologies in terms of information management, et cetera, to kind of alleviate some of the burden, that part of the burden. But anyway, so hearing that, I thought, gosh, there are great patient advocacy organizations. You're part of one today. But it's the medical community that I want to try to reach as well. And of course, we've got the tool of the internet and the sharing culture that we're now in. Now, on the other hand, you create a website, doesn't mean people will see it, right? I mean, how many are there, right? I'm sure it's countless probably now. But nevertheless, I was born in Spain, and if you know the story of Don Quixote, he goes out there and does the battle anyway, right? Maybe the chances aren't high, but we're just going to keep pushing, all right? And so I registered chiarimedicine.com. It's available to anyone. It's open. It is written a bit more at the professional level, but I think it's going to be very understandable to most folks. And what I do need to do is just simply post more often, but I'm working on a schedule. I will post a variety of different things. Here's, for instance, just some images of callus formation. I've got other images. I hope to post video. And I do post research articles. I think my last post was announcing this presentation. It does have now a Facebook page. And yeah, I broke down and got a Twitter page. I don't know that I've quite figured that part out yet. So I'm not going to go there. But clearly we're getting some Twitter followers. It's still small right now, and we're getting some people to go to the Facebook page. And I'm starting to understand the value of all three of those together. This is the main information, but a quick link can be through those other services. So this is your site as well. So I think maybe what occurred to me today and the issues that we're discussing is, you run into that doctor. They're kind, they've trained hard, but they just don't seem to connect to Chiari because it was just not part of their radar early on. If you find something on this site, print it out, give it to them. They then have free access to this. I have my email address on there. They can email me. A number of them want to get knowledgeable, but how difficult is it in an area that you don't even know where to start, okay? And so that's the goal, if you will, over time. Well, anyway, let me summarize. We started off talking about associated disorders. We need to consider them. We need to have them on the radar. A lot of times they won't be there, but when they are, we have to take them seriously. And the one in particular we're focused on today is this pseudotumor. Surgical treatment is steadily advancing, but is not consistent nationally. So yes, we still all have a lot of work to do with education and training. Okay? We've showed you what seems to be a powerful tool for measuring outcome, at least based on the symptoms, what's called patient-centered outcome that's meaningful to the person that has it, if you will. And we believe that a nutrition program focused on reducing inflammation and normalizing body weight, it should say, are essential. And again, I thank you. It's a real pleasure. It's great to know you. Thank you for allowing me to be here. I think we left some time for questions. Is there? Okay. Yes, I'll repeat questions. Thanks. All right. Yes, please. We'll go around the room.
When it comes to determining if there's a veil over the
Uh-huh.
form of Magendi, is that something that can be seen through diagnostic testing or only by going in?
If you get a cine flow study and the image is lined up well along that area, the outlet of the fourth ventricle, the radiologist will often report whether they're seeing flow or not in that part of it. Now, they may not see it because it's not quite lined up. That I'm aware of, nobody's yet done the study of correlating what you see on those MRI cine flow to what they actually had in surgery. Okay, but I think that certainly could be doable. The thing is syringomyelia, Chiari syringomyelia is less common in the Chiari population. Some studies 20% is, others higher. So you already have a small group of patients. Then only, say, roughly 10% are going to have a veil. So it's probably going to take quite a bit of time of collecting the information to know if we can reliably detect it on cine. But that could be. I was going to move around. Yes, please. Mm-hmm.
What about, I have a blood clot in my brain, so I think that's part of my problem.
Uh-huh.
As far as the intracranial pressure,
Yeah.
the only way to check for that is to do spinal tap.
Well, it's the definitive way. And people can have these pseudotumor without Chiari, where there's no significant crowding there. And then certainly they get a spinal tap. And then they find out. Years ago, before we recognized this syndrome very often, some people would become blind eventually because it'll lead to blindness. If the Chiari is crowded tight, maybe like some of those I showed you on those videos, there is some risk of doing a spinal tap.
But after surgery, you're fine.
But that's the thing. That's why Frem found it after surgery. He can then do a spinal tap. Scan looks good, and that's been an issue ever since I, maybe 17 years ago, got more interested in this area is, wow, the scan looks really good. And yet, you've got a lot of symptoms ongoing, and it's a hard fit. When this is open, we can do a tap. Pressure's high. I give them the nutrition lecture. That's hard, I realize it. Usually the next thing is a shunt. Once this is open, a shunt can be considered. Problem if the BMI is very high, shunts aren't going to last that long. Actually, one study has shown 50% will fail. So clearly the best thing for somebody who's quite large is body mass reduction. And that can cure the pseudotumor. I mean, it'll go away, okay? So going from here to here is crucial. There are some ways to do that, but they're not easy, okay? So, and I do have some patients that are very gung-ho. I have a lady with 12 millimeters of tonsillar herniation, miserable headaches, 270 pounds. She went all over the nutritional program. It was really intense. Initially wavered a little bit, but she is probably close to 2 years out now, and she doesn't want her surgery. So here's a 12 millimeter situation that is beating the syndrome so far. You know what it might be in some, and it's hard to know, it's that maybe people have started out with a little bit lower tonsils. Now the body mass goes up and this brain gets large for whatever reason, and there's enough to tighten it. And I call it once the malformation gets activated, when symptoms are triggered. I mean, the common question is, why did I have this for 25 years? And this past year or two, I'm having a hard time, okay? To me, the Chiari becomes activated at some point in time. It has to. I mean, that's the only way I can think through it. And when we look at these pulsation studies, that's been happening so often. I mean, that what I imagine is maybe coughing, sneezing, straining, maybe some other factors. Eventually, it gets tight enough. It's getting tight, but you're doing okay. It gets tight enough that any increase in pulsation now is just going to make it tighter. it's never going to relieve. I mean, I did have 2 ladies that early on in life would do an inversion table and would relieve their symptoms. I mean, you might be able to pull them back down. But I guess one of the reasons I want to talk about this, and others are, don't get me wrong, is we within the community need to face this disorder a little heavier. As a matter of fact, credit CSF last year for having Dr. Ricate talk about this disorder. And so there are a number of folks that are considering it, but we need to come up with, or at least I feel within our own office, we need to come up with definitive ways and plans to manage this. I didn't answer part of your question, or part of the question, that is, what about if there's bad Chiari, very high body mass index, blood tests that suggest significant inflammation in a person that doesn't have time? In other words, you're in a real crisis. I mean, what are you going to do about the Chiari? What are you going to be doing? There, what I'm doing right now is they're coming in early, and I think I mentioned this, in monitoring their pressure. If I can't get an LP to tell me their pressure, I'll go above the block where I'm not going to cause any worsening. And if their ventricles are big enough that I can slide a catheter, I'll measure the CSF pressure. But if not, and you saw those tiny little ventricles, I could put a shunt safely in there. They'll have just a little bolt that goes to just the superficial part of the brain here that somebody with a head injury would have if you're monitoring their pressure. And then I monitor them for a couple days. And if they have high pressure, we know we shouldn't do surgery because they're likely to leak. If a person has a pseudomeningocele, they need to worry, why did I leak? So anyway, you can see that it's a complex issue. It doesn't have a simple answer. Let me move along. I thought there was a question on this side here.
A lot of us have numerous tests done. Comparing the MRI to the TCD bubble test, how informative is the TCD test as far as the proper flow of the highways to the brain?
You're talking about the transcranial Doppler. So the transcranial Doppler is looking at the arteries. Okay, I mean, we can look at veins there, and you can look at the larger veins. What I'm doing instead of transcranial Doppler is an MR venogram, because it is benign to you. It's like an MRI, and they're going to look at the veins themselves. It's a 3D map that looks at the veins. The problem is that all of us have some irregularities of veins, like these 2 big draining highways here. One can naturally be smaller than the other. I mean, that's not unusual. And some can have a little bit of irregularity to them. And so I think it's finding a neuroradiologist that's sort of more knowledgeable and comfortable with that disorder. Because I can tell you, when I get them in our place, they're usually read as negative. Now, I look at them myself, and if I have any question, I might send them up the street to the fellow at the university that I know. And then, since there are irregularities, it may be that the transcranial Doppler would also be a little more difficult. Yes?
Can you have a pseudotumor if you've been checked by, like my eye doctor's checked before?
The back of your eyes? Yeah.
And he doesn't find anything.
Right, and I'm glad you brought that up. That's very important. Well, what we're learning is there's a gray area. So if the pressure is high enough, yes, you likely should have papilledema, swelling in the back of your eyes. And that's been in the textbooks for many years. That's how I was trained. We have to realize that the folks we saw back then were often missed even longer, and they got to that point where a lot of them had the papilledema. Now we know there's a gray zone of about 10 points on the scale, if you will, where, frankly, a lot of people fit, but don't have the papilledema. So I do have some of my own that I've gone ahead and tapped, and they've had high pressure but no papilledema. And now the pressure doesn't mean it's way off the wall, but if it's 25, it's still 2.5 times normal. It gets complex into numbers. I don't need to get into all of that, but no, it's helpful. And what I tell my folks, and we do check their eyes. We have an eye specialist across the street. Their team looks at many of our folks. Most of those studies look normal. But if their BMI is high, what I can tell them, if their eyes are normal by visual studies, they likely don't have the very high pressures, but they could still have significantly above normal to cause headache, dizziness, et cetera, et cetera. No, that has other mechanisms, we believe. Yes, please.
So then, in line with what you're talking about, with blurred vision, like my daughter has had the surgery and she still kind of continues to have episodes of blurred vision. It's not blurred all the time. Just took her to the eye doctor recently. He said, I see now increased pressure there behind her eye. Literally that evening, she's sitting there reading, and then the left eye goes blurry. Would this be possibly what you're talking about, that maybe she has a higher CSF pressure?
Well, one eye gets a little tricky, but in general, blurring or graying out of vision, I have increased headache, my vision comes down, or things just seem to suggest the possibility of high pressure. It needs to be considered. And then maybe a family doctor that's learning more about the non-inflammatory approaches. Food for some of us is inflammatory. I didn't want to get into that today because I usually don't stop when I start on that topic. And you guys have other things well, so the bottom line is we have to ask ourselves if the diet that we ate before agriculture is not maybe our natural diet, because that's for hundreds of thousands of years. Now, I'm not an absolutist about this at all, but we put grains in the diet, and a lot of us are adapted to grains and can do fine. Well, some people can smoke until they're 98. I mean, who knows? But unfortunately, the grains are the suspect right now in some people of being inflammatory. The one substance that we clearly know is gluten. The protein within gluten is called gliadin. It is associated with 3 neurological disorders. Let me just give you, I'm going to come at it just in a slightly different way, because we're getting pieces of information like this and it's going to take a while to put it all together. But one of the tests we get is CRP. And if you're having struggles, and if there's a body mass issue, get your CRP done, C-reactive protein. C-reactive protein. You might as well get your hemoglobin A1C. That's looking at, are you taking in too much sugar, basically. And vitamin D, we see a lot of people with low vitamin D, and that affects so many different systems. So again, the test that I showed you there, homocysteine plus minus, but these 3, get them. I mean, it's just a blood test. It may, and actually that's what happens in the clinic. Some folks have never had these tests done or haven't had them done in a few years. And if you have a CRP, depends on your lab and what scale they use. If you have a CRP of greater than 3, that's a 90% risk to cardiovascular event. I've got people coming in at 9s and 10s that have never known that. We've got something to help now, okay? But what I was going to say is CRP. And we'll wind up here in just a second. This is a large study. It's published. It's 600 people. Their average age is 63. They drew CRPs. They then took those people with the highest CRP and compared them to the lowest CRP people, okay? So average age in both groups the same. Then they stuck these people into an advanced brain MRI to look at, in particular, the frontal lobes and the tracts, judgment, memory, thinking, personality, etc. Average age the same. The only difference in these 2 groups is CRP, okay? These brains were 12 years older than these brains. The amount of atrophy and loss was 12 years difference, okay? Alzheimer's Association says 1 out of 8 of us is going to be demented. That is unacceptable. We need a society to figure that out. And when I start seeing people, midlife or so, starting to worry about memory, thinking, I'm not as sharp as I used to be. Recent study on glucose. If your glucose is higher than normal but not diabetic, chances are your hippocampus in the brain is starting to shrink. That's where you store memories. So we're starting to tease, or the scientists are starting to tease out, that some of this diet is inflammatory. And again, I better stop because it's hard to stop. All right. Well, thank you again. I appreciate it.